All right, can you hear me now?
Yes.
All right, let me just remove this screen here. All right. So I'll be talking about SGLT2 inhibitors at kidney transplantation today. So to start off, I have the two cases. So these are the two cases that I've been asked about to use SGLT2 inhibitors in the clinic. So patient A is a 62-year-old male. He has a history of obesity, diabetic kidney disease. He had a kidney transplant 5 years ago. His diabetes is managed with metformin and insulin. His hemoglobin A1C is 7.8 to 8.5. He has a stable allograft function of 52 mLs per minute, and he has albuminuria of 400 milligrams. He has no history of infection. Patient B, on the other hand, is a 53-year-old male. He has history of CAD. He had a 5-vessel CABG and ESRD secondary to diabetes. He recently got transplanted about a year and a half ago. His diabetes is managed with insulin. His hemoglobin A1C is 8 to 8.9. He has stable allograft function of 59 ml per minute. He has albuminuria of 300 milligrams, and he has a history of skin infection on different parts of his body treated by dermatology about 6 months ago. So throughout the course of this talk, I'd like you to think about these two patients, and also possibly, the transplant patients that you're caring for in your clinic. I did poll ahead of time about 14 attendings to select, if they would give SGLT2 inhibitors to patient A or patient B, both or neither. So out of the 14, actually majority answered both. They would give it to both these, so about 9 out of the 14. 2 out of the 14 actually said no, they would not give it to any of these two patients. And the rest is sort of back and forth whether or not they would just give it to patient A. So about 2 to 3 years ago is when I was first asked by a primary care doctor if I would consider an SGLT2 inhibitor in a mutual patient. Knowing that it causes glucosuria and what we were taught in medical school that it predisposes to infection, I quickly replied no. I also added that there are other alternatives, so just use that. Now, I would get this question every now and then. However, now with the flux of literature showing the cardioprotective effect and renoprotective effect of SGLT2 inhibitors, I had to rethink my answer. I had to reevaluate my answer and see if I'm missing an opportunity for my patients to benefit from these effects. So for this talk, I'd like to weigh the benefits and risks of SGLT2 inhibitors pertinent to kidney transplant patients. I will give a brief overview of the benefits of SGLT2 inhibitors in diabetic kidney disease. I will spend lesser time on this, as I know most of you are aware of these landmark studies, and the fellows are probably aware of Credence and DAPA-CKD and know these by heart. We will see if these efficacies are seen in transplant recipients. And we will explore what are the main risks of use of SGLT2 inhibitors in kidney transplant patients. And lastly, I'd like to propose an approach in selecting kidney transplant patients who may benefit from SGLT2 inhibitors. So just in terms of glucose handling and diabetes, in diabetes, the proximal tubule hypertrophies, and there's a fourfold upregulation of sodium glucose cotransporters such that the reabsorption capacity is increased from a normal range of 180 to 200 to about 200 to 300. And of course, this is a maladaptive response and contributes to further hyperglycemia. And what SGLT2 inhibitors do is that they dramatically reduce the threshold at which glucose excretion begins. And this may begin with a plasma glucose concentration well below the fasting levels, around 85 to 108 milligrams per deciliter. So what are the benefits of SGLT2 inhibitors in diabetic kidney disease? So in patients with preserved renal function, SGLT2 inhibitor-induced glucosuria leads to hemoglobin A1C reduction of about 0.6 to 0.9%. Now, the glucose-lowering effect is directly proportional to the glomerular filtration, so as the kidney function decreases, your glucosuric effect also gradually decreases, and hemoglobin A1C reduction is even less pronounced at around 0.2 to 0.4% change in CKD stage 3, and no effect in hemoglobin A1C change is seen in CKD stage 4. Now, for weight, as opposed to other glucose-lowering medications which are associated to weight gain, SGLT2 inhibitors result to weight loss of about 1.5 to 2.5 kilograms. And weight loss starts early, as early as 3 days after taking the medication. And this early effect is attributed to natriuresis. This natriuresis is found to attenuate over time, but weight loss continues. And this continued weight loss is thought to be due to reduction of adipose tissue. Now, for systolic blood pressure, it reduces systolic blood pressure modestly by 3 to 5 millimeters mercury, and the diastolic blood pressure by about 1 to 2 millimeters mercury. Now, while hemoglobin A1C and weight loss are attenuated with your EGFR, systolic blood pressure is actually not affected and is preserved regardless of EGFR. And they mentioned that this is likely due to the natriuretic effects. In addition to these 3 parameters, it was found that SGLT2 inhibitor also decreases uric acid and also increases hemoglobin. Now, as the story goes, in late 2000s, there were concerns raised about cardiovascular risk of rosiglitazone, so this prompted FDA to issue draft guidance that has required large cardiovascular outcome trials, or CVOTs, for all new type 2 diabetes therapies. Since that time, there has been a variety of large cardiovascular outcome trials to satisfy regulatory requirements. Those highlighted in red are those of SGLT2 inhibitor trials, all of which showed a robust cardioprotective and renoprotective benefits of SGLT2 inhibitors. So pointed out in this meta-analysis of the 3 big trials of empagliflozin, canagliflozin, and dapagliflozin is a robust benefit in reducing progression of renal disease, regardless if they have atherosclerotic disease or not. However, most participants in those trials were low risk for end-stage kidney disease, so the effect on endpoints such as need for dialysis or transplant is uncertain, just basing it on those studies. So here comes credence that included patients at higher risk of developing renal hard endpoints. They included diabetic patients with EGFR ranging from 30 to 90 ml per minute, and albuminuria of 300 to 5,000 milligrams. All patients are on steady dose of ACE inhibitors and ARB for at least 4 weeks. And the primary composite endpoint is of end-stage kidney disease, doubling of serum creatinine, and renal or cardiovascular death. What they found was that the composite outcome of ESRD, doubling creatinine, and cardiovascular death was lower in the canagliflozin group compared to the placebo group at 43 and 61 per 1,000 patient years respectively, which resulted to a 30% lower relative risk. They calculated the number needed to treat to prevent the primary composite outcome at 22. Fairly impressive. Now, with the building literature in the renoprotective effects of SGLT2 inhibitors, KDIGO had its first diabetes management guideline that came out this year, and Dr. Ian DeBoer led, recommend that after emphasis on lifestyle modification, such as smoking cessation that Leah talked about last week, KDIGO recommends to start SGLT2 inhibitors to patients with diabetic kidney disease as first-line therapy along with metformin. Now, just to briefly mention the recently published dapagliflozin, DAPA-CKD, that was published just 2 months ago. The difference of DAPA-CKD to credence is that it included CKD patients without diabetes. About 32.5% of the patients did not have diabetes. And also the mean eGFR in DAPA-CKD was also lower at 43 mLs per minute. And they also included patients with an eGFR of less than 30 ml per minute. About 14.5% of those patients had an eGFR less than 30 ml per minute. And they found the same renoprotective benefits with a number needed to treat of 19. Now, what's the mechanism of renoprotective effect of these medications? So in diabetes, there's this disproportionately reduced afferent versus efferent arteriolar resistance brought about vasodilators such as atrial natriuretic peptide, nitric oxide, prostaglandins that preferentially reduce the resistance in the efferent arteriole. By contrast, the vasoconstrictors, angiotensin II, thromboxane, and endothelin 1 preferentially increase the efferent arterial resistance. This imbalance results to this scenario where you have an increased intraglomerular pressure and over time results to sclerosis. Now, in addition to this, tubular function also impacts glomerular hemodynamics in diabetes via tubulo-glomerular feedback. With the upregulation of sodium glucose cotransporters and the subsequent increased reabsorption of both sodium and glucose, as I've mentioned earlier, there's decreased sodium chloride delivery to the macula densa portion of the distal tubule, and consequently, arteriolar resistance is decreased. And this further worsens the imbalance that contributes to hyperfiltration. Now, SGLT2 inhibitors result to the opposite. By decreasing the reabsorption of sodium and glucose, there is more sodium chloride delivered to the macula densa that results to increased afferent resistance, resulting to reduction in intraglomerular pressure. So along with RAS inhibition, it was thought that they synergistically restore the normal intraglomerular pressure. Now, inhibition of sodium and glucose reabsorption in the proximal tubule can also lead to other potential beneficial processes in the kidney. For instance, it can lead to improvement of mitochondrial mechanism, decrease hypoxic damage to the proximal tubular cells, and reduce intrarenal inflammation. Speaking of inflammation, in diabetes, activation of the immune inflammatory pathways is recognized as a key mediator in development and progression of CKD and diabetes. There's an interesting study that looked at the inflammatory biomarkers in diabetes and the effect of canagliflozin on these biomarkers. What they found was that canagliflozin reduces inflammatory biomarkers, tumor necrosis factor receptor 1, interleukin 6, metalloproteinase 7, and fibronectin 1, suggesting that canagliflozin contributes to reversing molecular processes related to inflammation and extracellular matrix turnover. This was interesting to me, especially because we know, for instance, that IL-6, nonspecific as this marker may be, is also seen in allograft rejection. So with these renal protective mechanisms, these are definitely pathways that native kidney disease and allograft kidney share. So it is not completely far-fetched that a renal allograft will also benefit from SGLT2 inhibitors. But do we have adequate data in the transplant population? Compared to the large volume of placebo-controlled trials seen in a non-transplant diabetes population, I was disappointed to see that there is scant literature in kidney transplant population looking into the use of SGLT2 inhibitors, and most are case series. This is the lone placebo-controlled trial that I saw, and this paper looks into empagliflozin and if they can safely improve glucose metabolism in post-transplant patients. It is a single center study from Norway where they included 44 patients, 22 in each arm, and they followed them up for about 6 months. In general, the groups are well matched. About 75% of the participants are already on glucose lowering agents. Note though that the hemoglobin A1C in this study is not that terrible. And they also mentioned that some patients are also on antihypertensive medications. However, they did not discuss if it was a diuretic or an ACE or an ARB, which would be helpful if we would want to translate this to our patients. Now, what they found was that SGLT2 inhibitors are effective in lowering hemoglobin A1C compared to placebo. And they decreased about 0.2% compared to a worsening in the placebo group of 0.1%. What they found also is that if you have a higher hemoglobin A1C, then you had a greater reduction in your hemoglobin A1C at 1% compared to 0.1% if your baseline hemoglobin A1C is less than 8. There was no significant difference in blood pressure, but they noted that 2 patients in the empagliflozin group was able to reduce their blood pressure meds. I did not include that in this slide. Body weight is also decreased by 2.5 kilograms compared to an increase of 1 kilogram in the placebo arm. There was an initial reduction of eGFR after 8 weeks of treatment in the empagliflozin group at about a subtraction of 4 milliliters per minute compared to no difference in the placebo arm. However, there was no difference in the change between the 2 groups from week 8 to week 24. They also mentioned that there was no, in the study, there was no difference in CNI trough level at baseline and during the course of this study, just to bring about the fact that it probably doesn't affect your trough levels or your tacrolimus trough levels. They also note the relative increase in hemoglobin and hematocrit and reduced uric acid, which have been seen in other studies to appear to be important mediators of the cardiovascular benefits. Now, this is the meta-analysis of the scant number of studies, and they got 8 studies. Most of them are case series, and only one, the study that I just mentioned earlier, is the placebo-controlled study. The range of ages is 46 to 66 years old. The time after transplant is 3 to 20 years. The baseline eGFR of these patients are 54 to 86 ml per minute. And they found, significant reduction in hemoglobin A1C and weight, but they did not find any difference or any change in eGFR, serum creatinine. Now, this can be a positive or a negative. At least there wasn't any AKI or significant drop in eGFR, but it's not any better either. So this lack of data in the transplant population is contributing to the hesitation of use of SGLT2 inhibitor. This along with several FDA warnings that I will discuss later. Now, this survey actually reflects the different viewpoints that I've heard some folks say in the past. So they asked 44 physicians, in a suboptimally controlled patient with diabetes who is obese and has stable renal transplant, would you think it appropriate to use an SGLT2 inhibitor? And a lesser percentage of them, 20%, said that they would never use this on renal transplant patients. And their rationale were they do not want to make unnecessary risk in the absence of evidence. There are other safer options. Immunosuppressive therapy may increase the risk of genitourinary tract infections. There's also concern about dehydration and its impact on renal allograft survival. There's also concern about the initial reduction in the eGFR. The majority of them would use SGLT2 inhibitors in kidney transplant patients, and they mentioned the beneficial effect of SGLT2 inhibitors. And they also think that transplanted kidneys behave like native kidneys, and the chances of genitourinary infections are rare and can be treated with standard therapies. They also mentioned that volume depletion is actually mild and can be rectified by the intake of extra small amounts of fluids. So what are the main risks with the use of SGLT2 inhibitors in kidney transplant recipients? So there are several adverse events reported in SGLT2 inhibitors, and I will focus on these three: infection, bladder cancer, and AKI. These are studies in non-transplant patients, but should give us an idea about its application to transplant patients, especially in those at least a year out from transplant who are relatively on lower level of immunosuppression. There are several meta-analyses already looking at SGLT2 inhibitor trials, and all consistently found that genital infections are significantly higher in patients receiving SGLT2 inhibitors compared to placebo. This is not unexpected, given that pathomechanism causing increased vaginal yeast infection in diabetic patients is a change in the flora and the perineum brought about by the glyceria. Now, even if there are more genital mycotic infection in the SGLT2 arm in these studies, the rates are overall low. So genital mycotic infections occur in females more than males receiving SGLT2 inhibitors and are generally mild to moderate in severity and respond to standard topical treatment. And I mentioned topical because, of course, when you start antifungals and azoles, this will definitely affect your tacrolimus, and that accounts into the management of your patient. Now, rates of treatment discontinuation due to genital mycotic infections are low in the SGLT2 inhibitor trials. On the other hand, Fournier's gangrene is a rare but serious infection seen in diabetics with other concomitant risk factors. And actually, in August of 2018, based on post-marketing surveillance, FDA sent a warning about Fournier's gangrene with the use of SGLT2 inhibitors. At that time, there were about 12 reported. And to note, around that time, there were about 1.7 million individuals who have been dispensed an SGLT2 inhibitor. So in the Annals of Internal Medicine in 2019, a study looked into the FDA adverse event reporting data files. And they found 55 cases of Fournier's gangrene in patients receiving SGLT2 inhibitors versus 19 cases of Fournier's gangrene with the use of other antihyperglycemic agents. So the authors thought that the higher number of Fournier's gangrene reported in SGLT2 inhibitor users in such a short amount of time is reflective of association. There is, of course, an obvious uncertainty with reporting, as it is unclear what the rate is without a denominator. So as a rebuttal to that, this study, a nested case control study, they identified patients through claims database, and they looked for patients with diabetes who are hospitalized for Fournier's gangrene, starting in 2003 when the first SGLT2 inhibitor was available. And they matched each patient with Fournier's gangrene to 6 controls from the same cohort without Fournier's gangrene. And what they found was that there's no increased risk of hospitalization for Fournier's gangrene with treatment with SGLT2 inhibitors compared with treatment with 2 or more non-SGLT inhibitors or insulin. In another study out of Canada, they compared the incidence of Fournier's gangrene in 208,000 SGLT2 inhibitor users versus 208,000 dipeptidopeptidase 4 inhibitor users. Now, Fournier's gangrene is rare, so what they found was they're numerically similar in both arms. So the verdict is genital mycotic infections are common, but are mild and easily treated. And based on these studies, Fournier's gangrene is not associated with SGLT2 inhibitors. Now, how about urinary tract infections? So in 2015, again, following another FDA announcement, they added a warning about increased risk of UTI. So they looked into this, and this meta-analysis of 86 randomized controlled trials enrolling about 50,880 patients found that UTI was not increased in SGLT2 inhibitors compared to placebo or to any comparator. This is not to test your eyesight here, but just to show you that there's no significant difference on either arm. So the verdict for UTI is not increased in SGLT2 inhibitors. Now, how about a severe form of UTI, which is urosepsis? So this study looked into, again, 208,000 users of SGLT2 inhibitors and compared them with 208,000 of dipeptidopeptidase inhibitors. And the main follow-up year is about a year in patients. And what they found was that patients initiating SGLT2 inhibitors had a lower rate of urosepsis compared to those receiving dipeptidopeptidase. So the verdict is urosepsis is not increased in SGLT2 inhibitors. So how about volume depletion and AKI? So it is found that SGLT2 inhibitors are associated with increased risk of volume depletion and related adverse events, with SGLT2 inhibitors showing 0.3 to 4.4% compared to placebo at 0% to 1.5%. Now, despite the concern for the hemodynamic changes, SGLT2 inhibitors have lesser AKI compared to placebo. So the verdict is SGLT2 inhibitors have lesser AKI compared to placebo. Now, how about cancer? So they looked into 46 independent RCTs with a mean trial duration of about 61 weeks. And what they found was there was about 580 incidents of cancer among 34,000 individuals. And SGLT2 inhibitors were not significantly associated with an increased risk of overall cancer. Now they did for pre-specified cancer types, they saw that bladder cancer is increased, especially with empagliflozin. Most of the cases were found in the empagliflozin study, 6 versus the placebo. However, when they looked deeper, the bladder cancers were really rare, so just a little change in the number in each group magnifies the percentage for that. So they weren't exactly sure that this is related to bladder cancer, and no FDA warning has come out of this. Now, interestingly, canagliflozin might be protective against gastrointestinal cancer. So the verdict is SGLT2 inhibitors were overall not significantly associated with increased cancer. Now, looking at a meta-analysis again of the transplant population, the only thing that stuck out was urinary tract infection at 43.8%. But in general, urinary tract infection, at least in the first year, are noted in about 36% of transplant patients. So are SGLT2 inhibitors ready for prime time? Sadly, no, because there is lack of evidence, but I do think that it's ready for a really good pilot for this. So I'm proposing an approach for use of SGLT2 inhibitors. And as for patient selection, they would be kidney transplant patients with albuminuria greater than 200 milligrams, hemoglobin A1C not at goal, and based on KDIGO transplant guidelines that was published, I think, in 2009, that's around 7 to 7.5%. On metformin and other glucose-lowering medications, and at least 6 months post-kidney transplant. Now, I mentioned 6 months. Most of the patients are still closely followed up at this time, but at the same time, maybe on lower immunosuppression. And of course, I consider this just because tacrolimus can also affect the hemodynamic status of the patient. In terms of safety screening, they should have stable hemodynamic status, stable allograft function of greater than 45 ml per minute for at least 3 months, stable immunosuppression for at least 3 months, no history of recurrent UTI or skin infections, no history of bladder cancer, no history of severe peripheral vascular disease. And these are the lower dose. Start with the lowest dose of each medication. For anticipatory management, I recommend to reduce the diuretic by 50% or discontinue it altogether. And instruct the patient to drink at least 2 liters of PO fluid per day. Now, looking into the other recommendations in starting SGLT2 inhibitors, they recommend that if the hemoglobin A1C is less than 8.5, then you can reduce your sulfonylureas by 50% and the insulin by 20%. And if it's greater than 8.5, they recommend against reducing insulin, mainly because of the risk of diabetic ketoacidosis when you decrease your insulin doses significantly. Now for counseling, I would counsel my patients about hygiene, symptoms of hypotension, and symptoms of DKA. And I would also emphasize that if they're going to need antifungal drug, emphasize tacrolimus interaction and need to check their levels. And give them sick day precautions, like when they have diarrhea or when they have poor PO intake or nausea, to consider holding these medications, informing their docs and consider holding these medications. Now for follow-up, I recommend follow-up labs about 1 to 2 weeks after initiation, then every 4 to 8 weeks thereafter. And this is somewhat similar to when we're starting ACE or an ARB on a patient. And then lastly, consider stopping temporarily if the patient has diarrhea or low volume status, if they're undergoing surgery. There's another FDA warning about this, about undergoing surgery because of the risk of DKA. Now, consider stopping permanently if the patient is admitted with urosepsis, amputation, or DKA, and or severe perennial infection. Now, take-home points. In diabetic kidney disease, SGLT2 inhibitors is effective in lowering hemoglobin A1C, weight, and these are dependent on GFR, and blood pressure that's not dependent on GFR. In diabetic kidney disease, SGLT2 inhibitor results to cardioprotection and renal protection for patients. And SGLT2 inhibitor is significantly associated with mycotic genital infections, but these are mild and easily treatable. SGLT2 inhibitor has not been seen to have higher rates of UTI, urosepsis, Fournier's gangrene, or AKI versus comparators in non-transplant patients. And the evidence for kidney transplant is scant, but they appear to be safe and effective in lowering hemoglobin A1C. And lastly, there is no data on hard endpoints for SGLT2 use in kidney transplant patients, but the renal protective mechanism seen in native kidneys may be similar in transplant kidneys. Thank you.
Thank you so much, Iris, for addressing this important topic and unanswered questions. For the purposes of time, we're going to move on to Dr. Cowan's talk. I will note to everyone that on January 22nd, during Nephrology Grand Rounds, we've set aside an hour for a interdisciplinary discussion about SGLT2 inhibitors with guests from endocrinology, primary care, cardiology, and hopefully pharmacy. So I think we can continue to discuss some of these issues there as well.